Today's lecture is dedicated to pharmacology of narcotics and non-narcotic analgesics. Probably you know that pain is one of the most unpleasant things you can feel in your life. And 60–90% of visits to the doctor due to suffering from pain. If you have some disease, sometimes you don't even know about that. But if you feel pain, for sure it will lead you to the doctor. One of the very known, let's say, scientists, Albert Schweitzer, he was a doctor, humanist, Nobel Prize winner. He said that pain brings more evil to humanity than even death itself. Here you can see the phases of pain, physiology of pain. How does it work? How do you feel this pain? The first step is transduction. When you have some kind of the irritant, and this irritant may activate the receptors, which you have everywhere on your skin, mucosa, inner organs, surfaces. So these receptors, they send the information to the spinal cord through the peripheral nervous system. It's called transmission. Afterwards, you have the information is sent to the CNS, from PNS to CNS. This stage is called perception. And the last one is modulation, the answer for this information. General mechanisms of pain reception. We have two systems which are keeping the balance, nociceptive system and antinociceptive system. Nociceptive system is the system of pain reception, so it accepts the information about pain. And its physical appreciation with the launching of some defensive, conditional, and unconditional reflexive. At the same time, the opposite system is involved, antinociceptive system. This system is trying to suppress the feeling of pain. So basically, we can say that when you feel pain, you feel it much less than you could feel it if you wouldn't have this antinociceptive system. If feeling of pain reaches excessive levels, pain from the distress signal turns to source of distress and may cause shock, pain shock. Here you can see the structures which are involved in the nociceptive system. So which structures helps to accept and analyze the feeling of pain. Firstly, we have first order pain afferents. From this pain afferents, the information is going to the CNS through dorsal horn, spinothalamic pathway, second order afferents, then neospinothalamic pathway and paleospinothalamic pathway, and finally it reaches the third order afferents. We have it in somatosensory cortex, limbic system, thalamus, hypothalamus are involved. And at the same time, the antinociceptive system is involved. So in antinociceptive system, we have opioids. Opioids inhibit transmission of information. So opioid system, which we have in our body, is trying to suppress the transmission of the pain signal. Substance P is involved, and through nociceptive pathway, it goes to the CNS, and endogenous opioids stimulate descending inhibition. Pathway and potential therapeutic options for achieving pain relief. So basically, why do we need to know these pathways and how we can use it in pharmacological practice and in your practice as future physicians? So we have some kind of trauma. This trauma activates peripheral receptors, pain receptors, nociceptors. In this level, we can use few groups of drugs. So few groups of drugs are working on this level. Firstly, local anesthetics. Local anesthetics, they are inhibiting the afferent innervation, so they prevent the formation of the action potential and they prevent the transmission of the pain impulses. So the organism doesn't understand that we should feel pain. Then opioids and anti-inflammatory agents. What happens next? From the peripheral receptors through the peripheral nerves, dorsal root ganglion, information is going to the PNS and then to CNS. So in this level, how we can act? On the level of peripheral nerves, we can also use local anesthetics. For example, if you use infiltration anesthesia, or if you use conductive anesthesia, we can also block the feeling of pain on these levels. On the level of PNS of the spinal cord, we can also use local anesthetics. Probably you know spinal anesthesia or subarachnoidal anesthesia, for example. You know this kind of anesthesia, I'm sure. So this kind of anesthesia allows us to keep the patient conscious, but at the same time, this patient will not feel pain. Also, opioids, alpha-2 agonists, and anti-inflammatory agents are acting in this stage. And finally, we have our major organ, which is controlling almost all processes happening in the body, our brain. So which drugs are acting in this level? We have opioids, we have alpha-2 agonists, we have centrally acting analgesics, and the last but not least, anti-inflammatory agents. So we will start from narcotic analgesics or opioid analgesics. We have two terms, and for you not to be confused between these terms, I will explain what each of it means. Opiates. Opiates are drugs which are derived from opium and include morphine, codeine, and a wide variety of semi-synthetic agents derived from them and from thebaine and other components of opium. The term opioid, which is more common, which is more typical for you probably, is more inclusive, applying to all agonists and antagonists with morphine-like activity, as well as to natural occurring and synthetic opioid peptides. And the last one, endorphin. Endorphin is a genetic term referring to the three families of endogenous opioid peptides: the enkephalins, the dynorphins, and beta-endorphins. So what is the mechanism of pain transmission and interference when we are talking about opioid receptors, opioid or opiate receptors? So what happens? We have the pain signal, which is trying to be transmitted. How opioid system or opiate system can prevent this problem? We have endogenous opiate releasing neuron. Here we have our endogenous opiates. When the pain comes, this endogenous opiate releasing neuron is releasing opiates. These opiates interact with opiate receptors, and instead of being activated by pain information, these receptors are already blocked, so pain signals are not able to be transmitted in further structures to the receiving neuron. So basically these opiates, endogenous opiates, they block the transmission of nerve impulses. What is the intracellular mechanism of opioid receptors? All of them are G-protein coupled receptors. They're located on prejunctional neurons, inhibit the release of transmitters noradrenaline, dopamine, serotonin, GABA, and glutamate. Activation of these receptors reduces intracellular CAMP formation, opening of potassium channels through mu and sigma, and suppression of N type of calcium channels. And finally, ultimately, hyperpolarization and reduced intracellular calcium reduces neurotransmitter release. We have different types of opioid receptors, and each type of receptors has its own functions. So, first one is delta receptors. Delta 1, delta 2. Location of these receptors is brain, pontine nuclei, amygdala, olfactory bulbs, deep cortex, and the function of these receptors is that they cause analgesia. This is the main reason why we use opioid medicines. They can cause antidepressant effects, as you probably know, and I've showed you one of the first slides that pain quite often causes a lot of suffering of patients. And if this kind of pain is severe, if it's a chronic pain, quite often it may lead to development of depression. So antidepressant effect is very useful for such patients. But unfortunately, these receptors may also cause physical dependence. So patients become addicted to these medicines. Next type of receptors, it's kappa receptors, kappa 1, kappa 2, kappa 3 receptors. These receptors are located in the brain and spinal cord. In the brain, in hypothalamus, periaqueductal gray, claustrum, in spinal cord, in substantia gelatinosa. So these receptors are formation for spinal analgesia, for sedation, meiosis, narrowing of the pupil, and meiosis is one of the most typical signs of opioids overdose, and inhibition of ADH release. Next type of receptors, the last but not least in this slide, mu receptors. Mu receptors are located in the brain and spinal cord as well. In the brain, they are located in cortex, thalamus, striosomes, and periaqueductal gray. Mu1 receptors are responsible for the supraspinal analgesia. They may cause physical dependence. Mu2 receptors, they cause respiratory depression, also meiosis, euphoria, and euphoria is the main reason of psychological dependence, addiction to opioids. Reduced gastrointestinal motility and also physical dependence. So, what is the classification of narcotic analgesics? We have different types of classifications: traditional classification, structural classification, and functional classification. Traditional classification is due to the strengths of analgesic effect. We have strong-acting opioids such as morphine, diamorphine, fentanyl. You know the classic representative of this group, it's morphine. But fentanyl is the synthetic medicine. It is 100 or even 400 times stronger than morphine. Then we have medicine with intermediate action, such as partial agonists and mixed agonists, buprenorphine, pentazocine, and so on. And we have weak acting medicines, such as codeine. We will discuss codeine a bit later. Next type of classification, it's structural classification. We have morphines, we have phenylpyridines, we have diphenylprophenamines, and esters. And final type of classification, it's functional classification. We have pure agonists such as morphine and codeine. Pure agonists are those medicines which stimulate all subtypes of receptors. We have partial agonists, which are able to stimulate some subtypes of receptors, and others they do not involve. We have mixed action, such as pentazocine, nalbuphine, butorphanol. Mixed action means agonist, antagonist. I want to remind you that we have few types of opioid receptors, mu, kappa, delta. Also, we have sigma, epsilon. So mixed acting medicines, they may be agonists to mu receptors, for example, and blockers for kappa, or opposite. They can stimulate kappa receptors and block mu receptors at the same time. So mixed action, it's agonist, antagonist action. And the final group, it's antagonists. Antagonists, of course, we cannot use as analgesics, but this group of medicines we use for treatment of overdose, treatment of poisoning with opioids. Opium is the substance which was found by Friedrich Wilhelm Serturner, a German pharmacist, and in 19th century he isolated morphine from the plant that you can see on the slide. Morphine is the ancestor of the group of opioid analgesics derived from the opium. Opium is withered milky juice produced from unripe seed pods of Opium poppy. Opium contains about 20 alkaloids, and due to it, other analgesics with the same mechanism of action are named as opioid analgesics, and their receptors are known as opioid receptors. So here you can see the main pharmacological effects of opioid medicines, of opioid medicines. How can you easily remember these effects? Morphines. M, meiosis, they cause pupil constriction. O, orthostatic hypotension. Opioids may reduce the blood pressure. R, respiratory depression. Almost all medicines inhibit the respiratory center in medulla. P, they cause physical dependence. H, they influence upon the histamine release. I, they increase intracranial pressure and quite often it causes strong headache. N, they may cause nausea. E, they cause euphoria, and I remind you that this is the main reason why patients become addicted to these medicines. And S, they cause sedation. Of course, they have some other effects, but these are the most typical for opioids, and for you it would be easier to remember. So, how morphine influences upon the pain sensation? Firstly, it has two components. Spinal and supraspinal. So morphine causes spinal and supraspinal analgesia. It inhibits release of excitatory transmitters from primary efferents at substantia gelatinosa of dorsal horn, exerted through interneurons, gating of pain. At supraspinal level in cortex, midbrain, and medulla, alter processing and interpretation and send inhibitory impulses through descending pathway. Pharmacological actions of morphine. Firstly, it has sedative effect. It may cause drowsiness and indifference to surroundings, inability to concentrate and extravagant imagination, colorful daydream, so let's say hallucinations. Apparent excitement, larger doses may produce sleep. This medicine also cause mood changes. In normal persons, calming effect, so sedative effect, mental cloud and feeling of detachment, lack of initiative, and so on. Sometimes these medicines may cause dysphoria. Unlike euphoria, which is a pleasant feeling, a feeling of happiness which arises from the unknown source. Dysphoria is the feeling when the mood may be changed. So now the patient is laughing, in 1 minute he is crying, then he is aggressive, then he's extremely kind. So changes of mood, and usually in the direction of bad mood. Also, morphine causes depression, respiratory center depression, cough center depression, temperature regulating center depression, and vasomotor center depression as well. So these medicines may cause dyspnea and apnea. In case of overdose or poisoning, they cause chain stop breathing, specific type of breathing. These medicines suppress cough center depression we can use for treatment of cough, unstoppable, exhausting cough, but dry cough. Temperature regulating center depression leads to development of hypothermia when the temperature may fall down below the normal level. And vasomotor center suppression may lead to hypotensive collapse in patients. Also, this medicine has stimulative effects. So this medicine may cause meiosis, may cause vagal center stimulation, which leads to bradycardia, and the hippocampal cell stimulation may lead to convulsions due to inhibition of GABA release. And I hope you remember that GABA is the major inhibitory neurotransmitter. So when we reduce the release of inhibitory neurotransmitter, it leads to excitation. Also, in gastrointestinal tract, morphine may lead to constipation. Constipation due to relaxation of smooth muscles and opposite spasm of sphincters. In smooth muscles, biliary tract, biliary colic closure of sphincters of Oddi. In urinary bladder, may lead to urinary urgency but difficulty, and in bronchi may lead to bronchospasm. When do we use morphine? Of course, the main indication would be severe pain, such as long bone fracture, myocardial infarction, terminal stages of cancer, when we cannot treat the patient, when we cannot cure the patient, but at least we have to relieve the suffering of the patient. Patients with burns, post-operative, post-surgical patients, visceral pain such as pulmonary embolism and so on, biliary colic and renal colic, spastic pain, obstetric analgesia, and segmental analgesia. Which adverse reactions do we have? Firstly, it's a respiratory depression. Respiratory center depression, it may lead to dyspnea or even apnea. Then this medicine can cause vomiting, especially when patients are using this medicine for the first time. Also, morphine causes sedation and mental clouding, hypotensive effect, rise in intracranial pressure, apnea in newborns, urinary retention, idiosyncrasy and allergy, and tolerance and dependence. Unfortunately, repeated use of morphine, not only morphine but other opioid analgesics as well, but morphine is one of the most likely to cause dependence. So repeated use of morphine cause physiological, psychological dependence, tolerance, and withdrawal syndrome. Tolerance is the reason of overdose of opiates. What does it mean, tolerance? Tolerance is the In simple words, it's reduction of the answer for the treatment. So after repeated administration of the medicine, each time when you use this medicine, it requires the higher dose to reach the initial therapeutic effect. So when the patient doesn't get the effects he wants, he has to increase the dose. And constant increasing the dose after repeated administration finally may lead to development of overdose and poisoning. Opiate withdrawal timeline looks like this. So after the last dose, if the patient was using short-acting opiates in 6-12 hours, after long-acting opiates in 30 hours, the symptoms of withdrawal appear. And after 72 hours, we have the symptoms peak, so the highest level of symptoms. Nausea, vomiting, stomach cramps, diarrhea, goosebumps, depression, and drug cravings. Next medicine I would like to discuss is tramadol. Tramadol is very specific medicine. So if morphine is classic opioid drug, so it has only opioid mechanism of action. Tramadol combines two different mechanisms of action: opioid and non-opioid. So what is tramadol? Tramadol is centrally acting analgesic. It is very low action on opioid receptors, and at the same time, other mechanisms involved in analgesic action, norepinephrine reuptake inhibition, spinal inhibition of pain. It may be effective both orally and intravenously, unlike morphine, which is not used orally. Side effects are similar to morphine but less prominent. It is well tolerated and low abuse potential, unlike morphine. Only partially reversed by naloxone because the mechanism is partially opioid. It may be used in chronic neuropathic pain and short diagnostic procedures. And finally, opioid antagonists. Antagonists are opposite to previous group of drugs. So we have discussed morphine, we have discussed tramadol. These are opioid agonists, stimulants of opioid receptors. And
Doctor?
opioid antagonists, after the lecture, please. So opioid antagonists, we have pure antagonists, naloxone, naltrexone, nalmefene. We have mixed agonists, antagonists, which are stimulating one subtype of receptor and blocking other subtypes. And we have partial weak mu agonists and kappa antagonists. Pentazocine. Pentazocine is the weak alpha receptor antagonist, but agonist to kappa receptor. It's one of the commonly used agents given orally and intramuscular. It has low abuse liability. And we use this medicine for moderately severe pain in injury, burns, bone fractures, cancer pain, orthopedic maneuvers. What is the difference? Comparison of pentazocine and morphine. Spinal analgesia via kappa receptor, unlike morphine, which influences upon all subtypes of receptors. Dose in 30 milligrams versus 10 milligrams and low ceiling effect. Sedation and respiratory depression at lower doses. Tachycardia and rising blood pressure, dangerous in myocardial infarction. Lesser smooth muscle spasms, vomiting and other side effects are less than in case of morphine usage. Subjective effects, it's lower ceiling, tolerance develops on repeated use, but lesser than morphine. Morphine is one of the most likely to cause tolerance and dependence.
Withdrawal symptoms are similar in morphine and nalorphine. Good analgesic in subjects not exposed to morphine, and precipitated withdrawal in morphine addicts. Buprenorphine. It's the synthetic thebaine congener and highly lipid soluble. It is given sublingually or parenterally. It's a selective mu agonist, not kappa, mu agonist, 20-30 times more potent than morphine. Slow but longer duration of action. Pharmacological effects are very similar to morphine. Has ceiling effect in analgesic and respiratory depression. Good analgesic for naive patients, but addicts precipitates withdrawal syndrome. Lower tolerance and physical dependence than morphine and abuse liability. Withdrawal syndromes are similar to morphine. And buprenorphine has also adverse effects, such as hypotension, respiratory depression, which we can mention almost in all opiates, and cannot be reversed by naloxone. We use it for long-lasting painful conditions such as cancer pain, in post-operative pain, post-surgical pain, and myocardial infarction. So, development of tolerance after repeated use of narcotic analgesics lead to overdose. What are the symptoms of overdose and how we are going to treat overdose of opioids? The most typical symptoms you can see on this slide. From CNS, patients may be unconscious, patients may be in coma, convulsions may occur as well. From cardiovascular system, we have hypertension and bradycardia. From renal system, urinary system, we have urinary retention. Pulmonary respiratory system, we have bradypnoea, and we have specific type of respiratory type, respiration type. It's called chain stroke respiration. This is one of the most typical signs of opioids overdose. Periodic breathing, gradual hyperpnea and hypopnea and apnea episodes, and hypoperfusion of the brain respiratory center occurs. So chain stroke breathing is one of the most typical signs of opioids overdose. And you have it in grog tests. So how we are going to treat such patients? Supportive measures and antidotes and some other medicines if required. Supportive measures include maintain patent airway, so maybe artificial ventilation, endotracheal intubation, and activated charcoal as the absorbent medicine to eliminate the metabolites. And of course, antidotes. Antidotes for treatment of opioid poisoning are opioid antagonists. So if we have treatment of if we have poisoning with opiate agonists, we have to use opiate antagonists to minimize effects of agonists. So naloxone is the opiate antagonist mostly used for treatment of opioid poisoning. It antagonizes actions of all opiates except buprenorphine. It reverses meiosis, respiratory depression, hypotension, coma. Naltrexone can be also used, and nalmefene in different doses. And as well, we can use another medicines if required to minimize the side effects. Naloxone, which we're just talking about, It's the competitive antagonists of all types of opioids, but blocks mu receptor at much lower dose. Always injected intravenously. All symptoms of morphine action are antagonized. Main one is respiratory stimulation, because respiratory depression, which is occurred after morphine administration, is a life-threatening condition. At higher doses, it antagonizes actions of nalorphine and pentazocine. Dysmorphic and psychomimetic effects are not suppressed. And withdrawal symptoms, morphine, nalorphine, and pentazocine in different doses. So that's it for opiate drugs. Thank you for your attention, and next lecture will be dedicated to non-narcotic analgesics.